Hello, I'm Julian Halcox, Professor of Cardiology at Cardiff University, and I'm going to be talking to you about endothelial dysfunction in coronary artery disease. So this talk is really going to be focusing on atherogenesis and particularly the where, why and how of plaque initiation, progression and destabilisation. And it's a huge topic to cover in half an hour, so I'm just going to focus on some of the elements of these processes that I find most interesting and think are most important to get a flavour of. So the progression of the atherosclerotic plaque is really what it's all about. Endothelial dysfunction is an important determinant of the site and the rate of progression of atherosclerotic disease, but clearly it takes more than just endothelial dysfunction to grow a plaque and to develop a lesion that's potentially likely to rupture and to cause an acute thrombotic occlusion, or to gradually grow and occlude the vessel so that the tissue downstream becomes ischemic. But essentially the most concerning element of atherosclerotic disease progression is progression of disease in a vulnerable artery, but particularly if the progression is such that you're predominantly seeing an uptake of inflammatory cells and uptake of modified lipid within a lesion that becomes rich in lipid, rich in inflammatory cells, rich in inflammatory activity, because the balance in this plaque will be one that promotes development of an unstable plaque, and this is one with a relatively limited amount of fibrous tissue, particularly limited amount of fibrous tissue around the cap of the plaque, and that the cap of the plaque is the side of the plaque adjacent to the lumen and the flowing blood. And a thin cap is potentially a vulnerable cap, and one that may rupture, crack open easily and expose the flowing blood to the contents of the plaque, which can of course promote the thrombosis, which results in the life-threatening acute coronary syndromes and many strokes. But how does endothelial dysfunction influence these processes? Well, if you go back to the preclinical situation, we know that if we look at endothelial function, and here this is a study that was performed in a large number of patients, one of the seminal studies by David Sellermeyer, and this is where endothelial function has been assessed non-invasively by ultrasound, looking at flow-mediated dilatation. We can see here that if we consider the various common risk factors for atherosclerosis, hypercholesterolemia, smoking, blood pressure, a family history of premature vascular disease, male gender, or age greater than 60, we can see here that with an increasing number of these risk factors that the individuals are exposed to, you see a gradual decline in the ability to dilate in response to flow. So progressive endothelial dysfunction associated with an increasing risk factor burden. Now, although the trend is down, you can see that the confidence intervals, the white error bars, are fairly wide, so it's quite possible to have a fairly substantial risk factor exposure, yet your endothelial function is better preserved than someone with a lower risk factor exposure, although the general trend is downhill, and more people with higher risk factor burden have worse endothelial function than those with a lower risk factor burden. So there's this general trend to having worse endothelial function with worse risk factors, but that's not always the case. Similarly, if you look at not just the exposure of risk factors to endothelial dysfunction, but if you actually extrapolate this forward in a prospective study, we have shown in a number of civil servants who've been studied over a period of 5 years. They've had their endothelial function assessed at the beginning of the study, and they've also had their carotid arteries scanned to measure their intima media thickness. And the carotid intima media thickness is a marker of early atherosclerotic changes in the carotid artery, which is of course one of the vessels that is particularly susceptible to atherosclerosis. And we can see here as you go from the tertiles of flow-mediated dilatation, this is endothelium-dependent dilatation of the brachial artery. As you go from those with the worst endothelium-dependent dilatation, the lowest FMD response here in tertile 1, through to those with the better endothelial function and the best in tertile 3, you can see that there's a gradual decline in the rate of progression of carotid intima media thickening over a period of approximately 5 years. And this relationship held even after adjustment for conventional risk factors such as blood pressure, lipids, glucose tolerance, smoking, etc., whether we looked at those as individual variables or as the Framingham score, and also when you added in other variables such as socioeconomic factors and C-reactive protein as a marker of inflammation. This relationship between endothelial dysfunction and progression of disease seemed to remain even after adjustment, suggesting that the endothelium is really a fairly important barometer of vascular health. It reflects risk factor burden and also reflects the environment that's promoting atherosclerosis or resistance to development of atherosclerosis. Now, if you look at a prognostic study that we did, we saw in patients who'd had endothelial function testing of the coronary arteries that individuals who had more dysfunctional responses to acetylcholine as an endothelium-dependent coronary probe, that their survival, free from mortality or major vascular events, heart attacks, strokes, coronary instability, requiring urgent revascularization and so forth, that their outcome was significantly impaired compared to those with better preserved endothelial function. And unfortunately, it seems that the survival curve for the people with modest coronary artery disease on the right, the ones with a more functional response hasn't projected on the slide, but their outcomes were significantly better than individuals with a more dysfunctional response to acetylcholine, suggesting really that not only is the endothelial function reflecting risk factor burden, reflecting the tendency for structural lesions to progress, but also is reflecting the risk for lesions to destabilize and to predispose to acute vascular events and major morbid events. So we can see it's triggered by risk factors, it drives disease progression and clinical events, but I think if we're looking in the coronary circulation, we need to understand how the vascular endothelium influences lesion location and morphology. And we can see here these three coronary angiograms showing on the top left that we've got a nice, normal-looking, smooth, unobstructed coronary angiogram. The angiogram in the middle showing, pointed to by the red arrow, a very tight, discrete area of narrowing in the middle of this intermediate vessel or high marginal branch of the circumflex, and a little bit of irregularity in the LAD which runs along the top of the middle figure. And over on the right, the angiogram at the bottom of the screen on the right, we can see severe diffuse disease. But what's important to note is that it's a more piecemeal process. It's certainly not a uniform process. And interestingly, these three patients could have a very similar risk factor profile. Not usual, not expected, but certainly can be the case. So it's important to know that atherosclerosis is a piecemeal process, but to understand it better, we need to understand why risk factors that tend to operate systemically, such as blood pressure, dyslipidemia, exposure to cigarette toxins, dysglycemic changes you see with diabetes and so forth, why these fairly uniform stimuli end up with fairly focal and piecemeal disease. And I think we need for this to go with the flow and to look at the influence of shear stresses on coronary vascular biology. And of course, if we look at this, and I've discussed this in more detail in one of my other talks in the course, but sites which are particularly susceptible to formation and destabilization of atherosclerotic lesions are bifurcations and curvatures. And what we note at these anatomical sites of the vessel, in the case of a bifurcation, we see turbulence, and if we think of a pulsatile flow, that turbulence will oscillate a little in relation to the pulsatility of the flow, and these areas of disturbed flow could potentially be what predispose the underlying vessel to develop atherosclerosis at these points. Similarly, if we turn our attention to the curvature, we know that if blood is flowing along at a constant volume, where it's turning the corner, the outer aspect of the curvature, the blood has to go a little faster, so the shear stresses, i.e. the stroking forces of the blood on the wall of the artery, are greater in the outer aspect of the curvature than at the inner aspect of the curvature. And we know from many observations over many years that atherosclerotic lesions not only tend to develop at sites of bifurcation, but they also are more likely to develop at the inner element of a curvature of the vessel, where the shear stresses are lower. Now, if we look at this in an experimental system, and here this is a system with cultured endothelial cells in a step flow chamber which are exposed to flowing blood, and we have flow being passed across these endothelial cells, and just at the beginning of the flow chamber is a little step so that there's an obstruction to flow, narrowing off the entry into the chamber, and therefore you get turbulent blood in the first. Here in the image, you can see the first third is particularly turbulent, and the site of maximum turbulence and flow disturbance is at the point of reattachment of flow, where the flow starts to become laminar again. And you can see that after 1 hour of culturing, which is the top row of the fluorescent images, these are the nuclei of the endothelial cells, and after just an hour of exposure to the flow, on the left and exposure to the turbulent flow, on the right exposure to laminar flow, you can see that these nuclei are very bright, and these are this is an immunofluorescent stain to steroid response element binding protein, which is a nuclear transcription factor, and there's similar data for NF-kappa B, which is an important inflammatory transcription factor which is relevant to atherosclerosis. You can see that just after just an hour of flow, these cells having been cultured in static conditions, there's upregulation of these inflammatory processes. But after 12 hours, you can see that it's only the cells at the reattachment zone where the flow is most disturbed that are still glowing bright. Over on the right, the bottom right panel, after 12 hours of exposure to laminar flow, there's no longer upregulation of SREBP1 binding in the nuclei of these cells, suggesting that this important inflammatory stimulus has been switched off, or at least turned down. And you see similar data for NF-kappa B. So this exposure to laminar flow essentially results in a switching off of the inflammatory processes, whereas in the area of disturbed flow, you have activation of the inflammatory processes. Turning